Okay, let's continue with part 2 of Module 1 of Alterations of the Integumentary. Pathophysiology of pressure ulcers are tissue damage that occurs because skin in the underlying soft tissue is compressed between a bony prominence and external surface for an extended period of time. Tissue compression restricts the blood flow to the skin, causing inadequate tissue perfusion and hypoxia, leading to cell death and hence pressure ulcers. Why do we care? It can cause chronic wounds that are slow to heal, cost a bundle to deal with, and can lead to sepsis, kidney failure, infectious arthritis, and osteomyelitis. So who are at risk? These are people with limited mobility and sensory impairment. Other contributing factors include friction and shear forces, inadequate protein intake, and chronically moist skin. Patients with mental status changes, patients who are bedfast, chairfast, poorly nourished, or incontinent patients. Some interventions to use to decrease the potential for pressure ulcers are: use a lift sheet when positioning, use pressure relieving surfaces like foam beds, silicone gel beds, or air beds, reposition the patient at least every 2 hours while in bed or every hour while they are up in the chair, possibly use mechanical lifts or a slide board, place pillows or foam in between the two bony surfaces, keep their heels off the bed surface, like using those POTUS boots or even a heels up cushion. You want to ensure there's adequate fluid intake, at least 2,000 to 3,000 mLs a day. Make sure their diet is rich in protein. Inspect their skin daily. Use daily moisturizer and apply it when they are fresh out of the bath. Avoid prolonged moisture with the skin. May have room humidity. Use moisture barriers if incontinent or near the wound drainage. Keep the skin clean, gentle cleanser in tepid water, not hot water. Use peri-wipes that contain a skin barrier agent. And you want to pat dry, never rub, and don't rub bony prominences. The amount of pressure is dependent on the weight experienced at the point of contact, distribution of weight at the point of contact, and density of contacting surface. Pressure is what causes the compression of blood vessels and leads to ischemia, inflammation, and tissue necrosis. Friction occurs when surfaces rub the skin and irritate or directly pull off epithelial tissue. An example of shearing is blood vessels in the skin become kinked or obstructed, and that leads to inadequate tissue perfusion and breakdown. We identify patients at risk for pressure ulcers by using the Braden scale, as you note here on this slide. You may also review the Braden scale on page 478 of your textbook. The Braden scale addresses categories of sensory perception, moisture, activity, mobility, nutrition, and friction and/or shear. There are stages to pressure ulcers. These are: suspected deep tissue injury. The area will appear purple to maroon in color, can have a blood-filled blister present, and may be painful. It's felt either firm or boggy, mushy. It could be warm or cooler than the surrounding tissue prior to this discoloration. In stage 1, the skin will still be intact, the area will appear red and does not blanch, and it's usually over a bony prominence. In stage 2, the skin is broken. The ulcer is superficial, causing partial thickness loss of the epidermis and the dermis, and may appear as a blister, a shallow crater, and or an abrasion with no bruising. Stage 3 includes full thickness skin loss. The subcutaneous tissue is damaged or necrotic. Damage goes down to the muscle fascia. Stage 4 includes full thickness loss with exposed muscle, palpable muscle, tendon, and bone. Unstageable is full thickness and base is completely eroded and covered with eschar, obscuring the true depth of the wound. There is a chart 27-3 on page 480 of your textbook that describes the stages of pressure ulcers in detail and pictures them on page 481 of your textbook. So what stage of pressure ulcer is this one and why? This is stage 1. Because the skin is intact, the area is over a bony prominence, the area is red and does not blanch with external pressure, and the borders appear defined. What stage of pressure ulcer is this one and why? This is a stage 2. Because the skin is not intact, there is partial thickness loss of the epidermis or dermis, and it is characterized as an abrasion, a blister, or shallow crater. What stage of pressure ulcer is this one and why? This is stage 3. The skin loss is full thickness. There is subcutaneous tissue damage. The damage does not extend to the bone, the tendons, or the muscles. And the wound has a crater-like appearance. So what stage of pressure ulcer is this one and why? This pressure ulcer is a stage 4. Because there is a full thickness skin loss, there is exposed bone, muscle, and or tendon. It will often include undermining and tunneling, and slough and eschar are often present. Eschar can be black, gray, brown, is non-viable, and is denatured collagen. Undermining is the separation of skin layers at the wound margins from underlying granulation tissue. And then remember, unstageable is the process of full thickness skin loss, and the base is completely covered with slough or eschar, obscuring the true depth of the wound. The dressing on pressure ulcers can make a huge difference. It needs to remove unwanted debris from the surface of the ulcer, protect exposed healthy tissue, and create a barrier between the ulcer and the environment. There is mechanical debridement and natural debridement, which can promote self-digestion of the dead tissue by autolysis. If dressings are too wet, then it keeps the new tissue mushy, but a dry dressing dry out the new tissue. Dressings are usually changed every 4 to 6 hours. Dressings can be hydrophobic. It keeps the wound is mostly free of drainage, and it just needs protection from the environment. And then dressings can also be hydrophilic, which draws the moisture away from the wound. Non-surgical management of wounds also include physical therapy, drug therapy, and nutritional therapy. Physical therapy can include daily whirlpool, dressing changes, debridement, and then to help remove the dead tissue. Drug therapy will include topical antibiotics if an infection is present. They will need a well-balanced diet rich in protein, carbohydrate, vitamin C, and zinc. For non-surgical management of wounds, we also have electrical stimulation and vacuum-assisted wound closure. Electrical stimulation can include low voltage pulsating current to wound area, promote blood vessel growth and granulation. It's usually done an hour a day, 5 to 7 times a week. There are single or multiple electrodes, and it is contraindicated in patients with pacemakers. Vacuum-assisted wound closure is a suction tube that is covered by a special sponge and sealed for 48 hours. It's on continuous low-level negative pressure that is applied. Its effectiveness is dependent on the seal. Can have bleeding complication if they are on anticoagulants, and you do not want to use near skin that has cancer. And the other non-surgical management of wounds is hyperbaric oxygen therapy. Hyperbaric oxygen therapy consists of high pressure oxygen. It raises the tissue oxygen concentration. It's expensive. It's safe for a life or limb threatening wound. And then it enhances the white blood cell's potential to kill the bacteria. And treatment lasts from 60 to 90 minutes. Wound eligibility for this treatment are burns, necrotizing soft tissue infections, brown recluse spider bites, and osteomyelitis. Surgical management of wounds is the removal of necrotic tissues, skin grafting, or the use of muscle flaps to close wounds. Surgical debridement can happen at bedside, treatment room, or in the OR, and you want to make sure the patient receives sedation and/or local anesthetic. Grafting is used for wound closure when full-thickness ulcers are unable to close. Grafting is because wounds cannot close or provide natural healing, which can result in loss of joint function. It is unacceptable to do grafting for cosmetic appearance. There is also unacceptable to do grafting if there's a high potential for wound reoccurrence. Post-op care includes to immobilize the graft site with cotton dressing for 3 to 5 days and do not disturb the dressing and elevate and immobilize the site. After the dressing has been removed, monitor for non-adherence, necrosis, and changes in color. Immediate post-op can include pressure dressing, pain management to medicate before the dressing changes. I want to check every 4 hours for pain, especially at the donor site, and then you want to monitor for pulses of affected extremity for the graft healing process. This concludes Module 1. If you have any questions related to the course content, contact the instructor.